Okay, so hello everybody. It's nice to see all of you again online. So let's talk a little bit about dengue fever, which is fast becoming one of the most important mosquito-borne infections around the world, one of the most widespread and certainly the commonest arbovirus. And at the end, we'll talk about why malaria and dengue are becoming, well, not malaria we've always known, but why dengue is becoming really, really important and maybe becoming as important as what malaria is. So, first of all, where does the name come from? We've heard of breakbone fever, you've heard of dandy fever. It's really a funny name. So, where does the origin of this come from? And the answer is that nobody's 100% sure. Maybe it comes from a Swahili phrase where they said "kadenga pepo," which, when translated into English, means a cramp like seizure caused by an evil spirit. Queen Louisa of Spain seemed to be suffering from dengue fever in 1801, and so she used the word dengue fever. And it seems like the derivation of the word implies muscle pain and joint pain, which is one of the main symptoms in symptomatic dengue, as the joint and muscle inflammation. So dandy fever is a really funny word. And this seems to come from the Caribbean when, in the beginning, when the outbreak started happening in the Caribbean, Pidgin English or Pidgin language on the island used a word called dandy, again, also trying to imply this terrible pain. And if you look right at the bottom, or on the side in bold, it says, from the stiffened forms and dread of motion in patients. So these patients really are so sore that they just lie absolutely still and don't want to move because they're too sore. So dengue's been around like most infectious diseases for long time. It was first recorded in 1992 in a Chinese medical encyclopedia. The first documented description of a dengue outbreak was in 1779. In 1906 is when the researchers discovered that dengue was in fact spread by the Aedes mosquito. And during World War I, in the late 1930s, early 1940s, there were massive outbreaks on battlefields amongst soldiers that were fighting in the world wars. In 1970, dengue was noticed as a major cause of child mortality around the world. And then, so we've had ongoing dengue epidemics. 2016 in the Florida Keys, 2022 huge and increasing numbers of dengue in the United States and around the world. And this slide, I just wanted to show you how there have been lots and lots of epidemics throughout time, and certainly now as reporting has gotten better, as traveling's become more widespread, lots and lots of dengue outbreaks and kind of transmission, and also in places around the world where we thought that there was no dengue. So you can see in the early 1900s, dengue in Greece and Spain. Oops. Dengue in Croatia and France in 2010, in 2013. Along with dengue often comes Zika because it's a similar mosquito, the Aedes mosquito, that also transmits Zika. And so these two arbovirus infections kind of follow along with each other. So let's talk about what the dengue virus actually is. Oh, and sorry, going back a step. So the first, how did it get onto the Caribbean and the dandy fever? We think that it probably went across with the slaves that were taken to go and work in the Caribbean and start farming and mines and other laboring type of work, and probably originated in Africa and then was brought across into the rest of the world through the slave trade. So it is a virus. It's a part of the Flaviviridae family and in the genus Flavivirus. There are four serotypes. There is a fifth serotype, but at the moment it's not really clear what the influence and the impact is for humans and whether this is a virus that has transmission in humans. It's enveloped, which is good news because it means that you can disinfect it easily. It's a single-stranded RNA virus, which is bad news because, as we know, RNA viruses are notoriously difficult to control in terms of prevention measures with vaccines, like we've seen with most RNA viruses. And you denote it DNV 124. Now, the good news for dengue virus is if you have infection with one of the 124 serotypes, this infection will confer lifelong immunity for the causative serotype. But the issue is that it's not sterilizing immunity for all dengue virus. So you'll be immune to, for instance, to serotype 1, but not to 2, 3, and 4. And as you'll see later, this is a major issue because if you've had one episode of dengue for one serotype, you are at high risk for having subsequent severe dengue if you get exposed to other serotypes. And this also has huge implications for the vaccination program because similarly with that, we need to have a vaccine that's going to cover all 4 serotypes so that you don't predispose a patient to getting an infection which is severe with another serotype to which they're not immune. But we'll talk about that a little bit later. So this is the Aedes mosquito. It's really a very beautiful mosquito because it's got these stripy legs, stripes white and black down it. And so it's really quite distinctive. And if you, the issue with the Aedes mosquito is that it's a day biter. So in Africa, we're so used to avoiding the Anopheles mosquito and trying to do nocturnal prevention from dusk until dawn. But the problem with the Aedes is that this guy is not around in the nighttime when we're putting on sleeves and pants and putting barrier sort of insecticides and nets and whatever. And the Aedes bites during the day when most people are out in the blazing sun, hot, got short sleeves on for not putting on insecticide. And so it becomes quite difficult to control. And so you can see that the prevention measures for dengue with this mosquito are not going to be the same as what they are for malaria. And so in those areas with high dengue transmission, the prevention measures need to include barrier protection for during the day. So how does dengue work? As with most arboviruses, there's a sylvatic cycle it's a zoonosis, in other words, in rural areas, in forests, in where there's non-human primates. The mosquito, the Aedes aegypti mosquito, will cycle this viral infection between non-human primates. The mosquito, like with malaria, gets infected when it has a blood meal from a person with acute dengue, so somebody who's not bacteremic, but viremic. And similarly in the wild with a non-human primate who's viremic, this gets into the midgut of the mosquito, undergoes changes in its life cycle, matures, and then gets injected through the proboscis into a human or a non-human primate and sets up a viral infection. Now, the epidemiology of dengue virus is changing dramatically. In the past, like I said, the infection used to be in sub-Saharan Africa, and mainly in Africa and the South Americas with the slave trade. But as time has gone on, as reporting's improved, but also with global travel, the epidemiology of the virus has changed dramatically. And so now we're sitting with a situation where countries which have never had or reported transmission, not imported cases, but cases within their own country where you're setting up transmission cycles where previously this was not happening, is now happening. And something like 120 countries around the world where there used to be no transmission of dengue virus, now there is transmission of dengue. What about dengue in sub-Saharan Africa? So the areas in gray, they did not have any data. It seems that in South Africa, and we'll look at this a little bit later, there is no set up non-imported cases of dengue, although we do have the Aedes mosquito, but we'll talk about that a little bit later. But in Africa, it's mainly around the equator and in the tropics where most of the infection is transmitted. But we'll talk a little bit about what could happen in South Africa and what we need to watch out for and what we should do about it. So again, I wanted to highlight and talk about this changing epidemiology of dengue. So this is reporting of dengue in the Americas, in Asia, in Oceania, and in Africa. And what you can see is that over the years, from the 1960s to the 2000s, there's been a massive increase in the infection rates, transmission, and reporting of dengue virus, not only in countries where one is expecting it, but as we said, in countries where we thought you could not transmit infection. Again, looking at another graph, this is looking at South America, where dengue we know has always been endemic. So even in the endemic areas, huge increases in dengue infection. Dengue in not just South America, but also North America, massive amounts of dengue. And so this has become really a big public health global problem to try and understand what's happening with dengue, why is this going crazy, and what can we do about it, if anything. So why is dengue increasing at such a rapid rate around the world? What are the kind of things that we think are responsible for it? First of all, we know that the world's global population has undergone dramatic, explosive growth with exponential increase in number of people, increased urbanization, so people living on top of each other, um, in very small confined places, overpopulation of areas, and in many of these areas around the world with inadequate public health systems to be able to control this. Now, unlike malaria, where the vast majority of transmission actually takes place in more rural areas, dengue, interestingly enough, actually transmission takes place in the urban areas. And that is one of the big changes that's happened in the last 10, 20 years. The second thing is that many countries have been really good about controlling the mosquito vectors for malaria, but in areas with poor socioeconomic circumstances, there's still massive issues with control of the vector as well as the conditions surrounding the growth and maturation of the vector. So we know mosquitoes need water, and during the rainy season, trying to keep areas dry and keep standing water away from where humans are staying in the form of tires that fill up with water when it rains, bowls living next to streams and ponds because of it being easier to get water is a massive problem for both malaria and dengue. The next thing is that we do think that there's been some viral evolution, that the virus has potentially adapted to infect humans over maybe non-human primates, and that it's also it adapted in ways in which it's able to evade the immune system and so propagate the transmission of this infection. There's more serotypes. I said there's now actually a fifth serotype, which we're not 100% sure what the implications for humans yet. There are case reports of infection with this fifth serotype, but we need to watch this space. The next one is obviously lots of global travel. With the ease of flying around the world, visiting places where access was in the past really difficult and limited. Now people are able to get to endemic areas a lot easier. The attractions in many of these areas are amazing. And so we're having massive amounts of travel into endemic areas, which wasn't seen previously. We know that the climate has changed, that there have been big environmental changes, and so global warming has also had an impact on the vector fitness and made the Aedes mosquito potentially able to last longer, to transmit, therefore, for a longer period of time. Winter's cold times are shorter, rainy seasons may be longer, and so global environmental changes has had huge impact on the dengue spread. And then lastly, as governments and many countries with less socioeconomic availability as these areas have had to use huge portions of their medical budget or even the total global budgets for the country on other things like COVID, for instance, many of the funding programs for mosquito control have fallen by the wayside. And we've seen a massive increase in mosquito control for malaria, with increases in malaria infection as a result, because they're not able to spend the money on spraying, on research, on things like trying to inject Wolbachia with into the viruses to try and control that, into the mosquito. And so the mosquito control, unfortunately, is not what it should be and promotes the spread of any kind of arbo infection, whether it's a virus or malaria. So let's talk about how to diagnose and what the symptoms of dengue are. And the problem with dengue is that, like most viral infections, it's really quite non-specific. There's a few flags which may make you say, think about this, which I'll show you. But overall, it's pretty unexciting compared to most viral infections and most febrile illnesses. So in any traveler and in any person who lives in a malaria or dengue endemic area, the first thing is obviously going to be, has the patient got malaria? And this should always be excluded in any traveler with a fever or any person with a fever in an endemic area. Many dengue infections have been misdiagnosed as COVID-19, and I think we all saw malaria being misdiagnosed as COVID-19 when all we could really think about was COVID and trying not to miss that, and in the process, missing a lot of other infections. And then dengue could really look like just about any other kind of severe viral illness, influenza, adenovirus. Because of the rash, it's often mistaken for measles, rubella. It could be misdiagnosed as a severe enterovirus infection. The rash could look very similar to a leptospirosis rash. It could be a tick bite fever, a rickettsial infection. It could look like a salmonella, so typhoid fever, and then obviously any of the other arbovirus infections. In terms of the non-infectious differential diagnosis, the rash and the joint pain is often thought to be autoimmune, and so people consider lupus, consider rheumatoid arthritis, consider Still's disease. In terms of malignancy, acute leukemia could look very similar, and then a drug reaction could always look like a viral infection with a fever and a rash. So the differential diagnosis is really broad and really requires some careful thinking to try and distinguish between the different syndromes. So in terms of dengue viral infection, the good news is that at the moment still, the vast majority of people who have dengue virus have an asymptomatic course or a mild symptomatic acute sort of viral illness. If it's symptomatic, most people will still have an undifferentiated viral febrile illness. But there's another three kind, which is going to be very difficult to distinguish between other viruses. And often if a person's sick for 2-3 days, they start getting better, we don't really pursue it. And so we don't make the diagnosis. And this is a problem because this has a knock-on effect to transmission. Whilst that patient is infectious and febrile and is viremic, they are at risk for infecting, obviously, Aedes mosquitoes, which are going to then transmit this onto the next person. But most people will still be okay, and it's not a dangerous disease in them. This becomes a problem if it moves on to one of the other three stages: a dengue fever with bleeding or without bleeding, a dengue hemorrhagic fever, which can be with shock, or so a dengue shock syndrome. You could have dengue hemorrhagic fever without shock. And then there's also unusual manifestations, being an expanded dengue syndrome, where these patients can often do it, not often, it's unusual, but an isolated organopathy, which is quite difficult because the diagnosis is then often missed. So they have an isolated hepatitis with not much else going on. And so it's really difficult to make that diagnosis. So as I've said, 3/4 of patients with dengue are going to be asymptomatic. The incubation period is 3 to 7 days, although it can go longer, up to 14 days. And that's the problem because that's pretty similar to malaria. So I put the 3 to 7 days in because usually malaria's incubation period is round about a week, can be longer, up to 14 days. But dengue, normally the patients will present within a couple of days of their infection rather than a week or a week and a half with malaria. So maybe that's one of the sort of potential distinguishing things, but that's always really difficult because hardly anybody will ever remember which mosquito is the one that infected them. And then to make our lives easier, there are some diagnostic criteria to help make the diagnosis in the setting of a febrile illness that looks like just about anything else. So first of all, you need to have a fever. And then the diagnostic criteria say you should have at least two of the following. So nausea and vomiting, a rash, a dominant sign of dengue infection are the aches and pains, so the myalgia and the joint pain, not just myalgia like influenza has, but actually arthralgia. Then you can try and do a tourniquet test, and I'll show you what that looks like. And then lastly, a leukopenia. But still, despite these sort of diagnostic criteria, I mean, this could be just about any viral infection. And then lastly, to add on and make it a little bit more sensitive, you really want this in a patient who is living in or who has traveled from an endemic area. So here's a reminder of the dengue fever symptoms. So it's multisystemic from head to toe, very non-specific. Many patients will have a headache. Most patients will have a fever. Eye pain is potentially something that's a little bit discriminatory. So it's often retroorbital and feels like a lot of pressure in their eye. The joint pain, bone pain, and remember that's where the breakbone fever name comes from, the dandy fever name comes from, is quite a dominant sign. So if you're trying to work out between influenza versus dengue, influenza usually does not cause bone pain or joint pain. It's usually influenza is pretty isolated to the muscles, although you can always get reactive arthritis, so it's never a never. Dengue, like almost all viral and malaria infections, nausea and vomiting, and then specifically the rash. So this is doing the dengue tourniquet test. What you do is you put a blood pressure cuff over your patient's forearm or upper arm, and you inflate the cuff to above the systolic blood pressure of the patient. Leave it for a minute and then deflate the cuff and look for these petechiae that develop afterwards. So this is quite a good test to try and distinguish, and easily done at the bedside to try and work out whether this is dengue or something else and whether the patient really warrants further testing. The dengue rash is a very non-specific erythematous type rash. So remember, the tourniquet test is kind of something that you have induced in the patient versus a rash which the patient comes complaining of, a diffuse erythematous rash all over the body. But can you see these areas of clearing? So dengue rashes often have these clear islands in the middle of the erythematous area. So that may be a little clue. And then lastly, it's often called a slapped rash. So if you apply pressure on top of the rash, it blanches. And you can see how they've put their hand on this patient's chest, which looks like quite diffuse, non-specific erythema or sunburn. But when you stick your hand on or put a bit of pressure on, you get the impression of that handprint as it blanches. So some things to discriminate and work out. Here's again an erythematous maculopapular rash, which could look very similar to measles. Sorry, it's a little bit blurry. It's maybe not the best one to have stuck up, but I think you get the idea of how this could be misdiagnosed as any sort of other viral exanthem. Okay, so we've said that the dengue is usually asymptomatic, but there's different phases of disease, and you could potentially go on to get dengue hemorrhagic fever, dengue toxic shock syndrome. So in dengue, these are the three main areas in which a patient is likely to go through if they develop the critical phase. So after the initial incubation period of less than a week, the patients will develop a high fever with any of those symptoms that we spoke about, a rash, nausea and vomiting, other gastrointestinal effects, severe muscle aches, joint pain, etc. And then during this time, patients often get dehydrated because of the vomiting. Their fluid status is not great. It's unlikely and unusual for patients to develop a hemorrhagic picture in this initial couple of days, which lasts for a week. Then we move on if you're going to develop it, and remember that most people will get better after the first week. But if you are going to develop severe dengue, day 6 and 7 are the critical time period when you really need to watch the patient very, very closely. Because this goes on to, if you're going to develop it, the critical phase of plasma leakage. What does that mean? It means that the capillary cells pull apart, you get fluid leaving the vascular bed, getting into the subcutaneous tissue. So patients start becoming quite puffy and, most importantly, dehydrated. They lose blood volume from the plasma leak. And so this is where you're going to find shock if it's going to develop. So how can you look out for that? So around about day 5, day 6, one of the markers is to look at the hematocrit on the full blood counts. And if the hematocrit starts rising, be very worried that the patient is going to go into a critical phase. If the hematocrit goes up and they develop the shock plasma leak syndrome, the good news is that it's very short, it's 48 hours. So it's a very predictable kind of course. You're going to have 2 days of this severe, and that's the part where one needs to really focus on looking after the patient properly and correcting metabolic abnormalities and making sure that they've got enough fluid to prevent hypovolemic and septic shock. If you can push them past those 2 days, then you go on to the convalescent stage where the plasma leak kind of stops, that increased permeability of the vascular system calms down. You get less leak, the intravascular volume and pressure normalizes, stabilizes. You start reabsorbing the edema, so the subcutaneous fluids. And 2 to 5 days later, you start looking and feeling like a person again, and being much better. So remember, if you ever make a diagnosis of dengue, the take-home message is from day 5, start doing daily full blood counts, looking for the hematocrit and watching very carefully for an overloaded extravascular volume with depleted intravascular volume of the hyperpermeability state. So in this stage, these are the patients who are potentially going to go on to develop dengue hemorrhagic fever. So during that stage with the vascular permeability, plasma leaks into third spaces, and it's at this point that one may have the hemorrhagic tendency. And then we don't know exactly what the trigger is, but if these people, there's probably a genetic predisposition, some kind of abnormal immune response, stimulating and igniting the cytokine storm, which we all understand so nicely from COVID now, and those patients who had that cytokine bonanza, and no matter what you did, they just did so badly. Similarly, in the dengue hemorrhagic fever, something triggers those cytokines, they storm, they pour fluid out, and you have a really unstable, very, very sick patient. And then lastly, there seems to be an antibody-dependent immune enhancement as well. And this is where what we talked about earlier in the presentation about having been exposed to dengue previously to one of the other serotypes actually sensitizes your immune system and can trigger those pre-existing dengue antibodies, can trigger an abnormal reaction predisposing to severe infection. So you get these immune complexes which have already been formed, which are not neutralizing, like I said, to a different serotype of dengue infection. And the problem with them is that they fix complement, they fix the FC receptors on the immune cells. It facilitates opsonization, but the immune cascade and storm as well. And so this results in a severe viremia and a dengue shock syndrome. So like I said, what are the red flags that we need to look out for to say, quick, this guy's not actually getting better, and they do defervesce actually. So around day 5, 6, 7, the temperature comes down and the patient initially feels quite better and you think, yay, it's going to be fine, he's going to be good. But then the drama starts. So look for the hematocrit, which rises, implying an increased plasma concentration. Look for a narrow pulse pressure. You can sonar the abdomen and look for the development of ascites, extra fluid in the abdomen. Look for edema around the gallbladder. Look for puffiness when you examine them, just fluid overload. And then obviously, of course, the dropping albumin levels, which may be difficult to interpret. So here's how it goes with severe dengue. So the first week is the viremic phase, which is hopefully where it's going to end. You get a fever, your platelets drop, your white cell count drops, you become leukopenic, and we'll talk about the diagnosis just now. But this is the stage in which you want to do a PCR so that you can actually catch that virus. Then at the end of the first week, if you go into the critical phase, look how the temperature disappears. And you think, oh, fabulous, the patient's getting better. So although they're not viremic, they're actually becoming dehydrated. Hematocrit rises, platelets reach their nadir. And in terms of diagnosis, you're not going to have a positive PCR anymore. You're going to have to rely on antibody testing. In the recovery phase, all the markers start returning back to normal. You may get a little fever, not as high as what it is in the viremic first week, but you may see a rise back to normal, slightly higher than normal, low-grade fevers. And the hematocrits, excuse me, white cell counts, etc., all return to normal. What are the complications? Like with most viruses, you can have neurological things like encephalitis, encephalopathy. That can be a trigger for Guillain-Barré syndrome. You can have a neuropathy. You can have hepatitis, pancreatitis, cholecystitis, nephritis. You can have cardiac manifestations in the form of myocarditis and pericarditis, myositis, abnormalities in your cell count. So really just about anything. So just to remind you about the diagnosis, we did talk earlier on the previous slide when to do what. There's direct and indirect methods. Direct method is to try and demonstrate and prove the actual virus, try and isolate the virus with a PCR, looking for the genome, looking for the actual proteins in the form of antigen detection, or the indirect methods, which one needs to use later on in infection, in other words, antibodies. So in the first week, you can look for a PCR. After the first week, in the first week, you can also look for the specific antigen protein. After about 4 or 5 days, you're probably not going to have a positive. And so one relies on looking for an IgM, which you then repeat after 2 weeks, looking for seroconversion to IgG. So if you're looking for dengue, acute dengue, and you pass the first sort of 5, 6 days, you always need paired serology. Remember that. So how do we manage these patients? The febrile stage is symptomatic. Don't use non-steroidals. So patients basically need paracetamol for headaches and pain. They need rest. They need antipyretics. And they need close monitoring towards the end of the first week. In the critical stage, these patients are dehydrated and need a meticulous fluid resus. And there are calculators online where you can actually work out exactly what your patient needs and how to give it. So you don't need to thumb suck this. In general, for a 50-kilogram person, you need to give them 4,600 mils of fluid over that 48-hour period to counteract all the fluid leakage from the intravascular. Unfortunately, at the moment, there's no antivirals for dengue. There's no proven efficacy with any antiviral. You'll give blood products as necessary. Remember, their platelets are going to drop. So if their platelets are too low and they're hemorrhaging, they're probably going to need blood. They're probably going to need platelets. Should you be giving steroids? It seems that the only proven benefits for steroids in dengue is in dengue myocarditis. Should we be giving these patients immunoglobulins? So there's unfortunately insufficient knowledge to guide the use of immunoglobulins. A very small case report described 5 patients who were treated with dengue antibody negative gamma globulins who had a rapid increase in their platelet count. But that's just one part of the whole story and not necessarily going to stop you from going on to get severe dengue and shock. Could antihistamines work? So again, a very small trial looked at ripatidine. I don't even know why they gave an antihistamine to a patient, maybe thinking that part of this immune bonanza cytokine storm was to block the antihistamines. So in this really tiny trial, ripatidine shortened the symptoms and reduced the disease severity. If the patients have got hepatitis and potential and are going on to developing liver failure, then N-acetylcysteine may be of benefit in those specific patients. I just wanted to show you all the millions, not millions, but multiple attempts at trying to find an antiviral drug for dengue, for this disease, which is just becoming such a big public health concern. And again, to try and look at all the kinds of things which they're thinking about for antivirals as well as novel therapeutics. Like with COVID, the usual suspects are appearing, like ivermectin. Could doxycycline be used in that first week? And then during the critical phase, using monoclonal therapeutics and trying to alter the immune response rather than the virus. The virus is gone. We need to get some kind of immune regulation then with mast cell inhibitors, metabolic targets like metformin. But basically, the bottom line is it's supportive from beginning to end, like what I've shown, with keeping control of the fever, the pain, and the dehydration in that way. So prevention really relies on vector control as well as vaccine development in trying to prevent this. Vector control, remember we said that this is a day-biting mosquito, so travelers to endemic areas need to be made aware that the barrier prevention that we always tell people about for the evening and the night should be done ideally during the day as well. They've also made attempts at trying to control these Aedes mosquito by infecting them with Wolbachia parasites, which causes interruptions in viral maturation and transmission. And so the vector doesn't support the virus when it's got Wolbachia in it. Spraying programs for mosquitoes with insecticide on walls and surrounding, spraying those areas, really important. And then lastly, looking at vaccine development, which unfortunately has had less than desirable effects up until now, although it looks like things are starting to become more promising. So to tell you a few words about the dengue vaccine options, at the moment, there's only one FDA licensed vaccine, which is called Dengvaxia, that has an efficacy rate of between 50 and 75%, depending on the type of serotype that so all 4 are in there, but for each one is going to have different efficacy. The efficacy of the Dengvaxia vaccine is heightened and improved if the patient has already had one episode of dengue. So if you vaccinate people who've never had dengue, there's decreased efficacy. So at the moment, the Dengvaxia vaccine is recommended and licensed for children who are aged between the ages of 9 and 16, because this seems to be a target area for dengue and high infection, high mortality rates. These children need to be in dengue high risk areas. and only if you've got previous history of lab confirmed dengue. So you need to actually prove that the person has had a positive serology for dengue before you vaccinate them. Otherwise, it's not very effective. We don't have any evidence for efficacy in people who are over the age of 16. So I've been having lots of people coming to my practice and saying, I'm going into these dengue endemic areas. Should I have the vaccine? So we simply don't know what the efficacy is in adults. The issue with the vaccine in general, not dengue vaccine, is like I said, being exposed to one serotype of dengue can actually increase your risk of a more severe disease outcome if you get infected with a second kind of serotype. So any vaccine which gets produced and trialed needs to produce neutralizing antibodies for all the dengue serotypes. So I think I've told you this already. The dengue vaccine, just to note that although it's marketed as covering all 4 dengue serotypes, it has very little to maybe no effect for the second serotype, dengue type 2. And so unfortunately, it's not used as well as what it should be because of the requirement for pre-screening. So you need to prove that you've had previous positive serology before you can give this vaccine to a young, well, let's say a teenager. They're really older children. The second vaccine is called Qdenga. This is not FDA approved. It was withdrawn in July last year. Future submission is uncertain. However, it is approved and available in Europe, in the UK, Southeast Asia, and South America. And this vaccine can be given to dengue naive people. And the reason why is that they feel that their vaccine has got better protection and neutralizing protection to most of the serotypes. Although look down a little bit further, its best efficacy is to dengue 2, with activity for dengue 3 and 4 being less certain, not just because they're not sure, but because there's less type 3 and 4 infections. So in many of the trials, there were no people infected with any dengue 3 and 4. So it's difficult to assess that efficacy. So it's not that it doesn't work, but rather that the 3 and 4 infection rate is much lower. It's a 2-dose schedule. You give it 3 months apart. It's got 84% efficacy against hospitalization at 4.5 years, so quite long-acting efficacy. It's 61% protection against symptomatic dengue at 4.5 years. Again, it's indicated between children who are between the age of 9 and 16. And you would try and give it a year or two before the age-specific peak incidence of dengue-associated hospitalization. So it's children where the biggest burden of mortality and morbidity is, like with malaria. And so you really want to give this vaccine a year or two before you expect them to get sick. At the moment, it's not licensed for travelers, but we're expecting that this year there will potentially be a recommendation to give to travelers with specific criteria. This is another vaccine which is in development. It's a single dose live attenuated tetravalent vaccine, so all 4 serotypes are covered. They've been trialing it in Brazil and in Bangladesh. 80% overall efficacy at 2 years, 90% to dengue 1, 70% against dengue 2, and again, no data on dengue 3 and 4, because again, there just weren't infections, dengue 3 and 4 in these patients. So what is it about, what's the differences quickly to discuss before we go on to South Africa and dengue, between dengue and malaria, and what are the things that we need to think about the differences? Because many articles, when you read it, saying dengue is the most important mosquito-borne illness, and at the moment it's probably surpassed, and malaria is more important. But is it becoming more important as transmission is extended, like we discussed in the beginning? So I want to show you that both dengue and malaria, 50% of the global population of the world are at risk of developing this infection. One is a virus, one is a parasite. One bites during the day, the mosquito, one bites during the night. Dengue, thankfully, most people are asymptomatic. Malaria, unfortunately, most people are symptomatic unless they live in endemic areas and are adults and have partial immunity. Dengue, if you look at the number of countries in which transmission is occurring in 2024 in the world, has got unfortunately more widespread potential for transmission and documented notification of increased transmission versus malaria, where the main burden of disease is in Africa and more than 90% of the mortality is in Africa. Dengue transmission occurs in urban areas, malaria in rural areas. Thankfully, the dengue mortality rate is much lower versus malaria. But remember that both have similar incubation periods, similar symptoms, and unfortunately, there's no effective antiviral medication for dengue, but very effective medication if given timeously for malaria. So before I end in the last sort of 5 minutes, let's quickly discuss dengue and the South African situation. So currently, dengue has not been detected in South Africa, and there is actually surveillance programs looking for the virus. But we know that there's potential because the Aedes aegypti mosquito is definitely present in our country, in KZN, in Limpopo, in Mpumalanga, and in Gauteng. There's no Aedes albopictus in South Africa, but we've also, along with having the correct mosquito, we've also got suitable environment, good climate, and as well as vector and population vulnerability. We're not really sure on the competence of the Aedes aegypti mosquito in South Africa. So there have been three, or I don't even know how to say this word, but it basically means 3 transmission cycles occurring in our country from the 1800s to 2016. But no local spread. So these were all imported through infected human travelers. One documented in 1897, one in 1901. These are a couple of cases, less than 100. The third one in 1926, 1927 resulted in 50,000 cases with 60 deaths. Again, these are imported where there seem to be local transmission set up. So the Aedes did get infected and caused local transmission. So those are the 3 sort of outbreaks in South Africa. 50,000 is pretty significant in 2 years. And it does make it worrying that the potential exists for our country to become endemic. From 2000 to 2016, the NICD has been notified of 176 cases, again, all of them having some kind of travel. The country of origin, most of these patients come from Southeast Asia or from Africa being north of us. Red comes from Central Asia, Central America, as well as Asia. So most of them from north of us in Africa and Southeast Asia. So what can we do about this in South Africa? What should we be doing to try and prevent South Africa from becoming an endemic country? First of all, really important and is actually up and running in those areas which I said a couple of slides ago, KZN being one of them. There are vector surveillance programs where the Aedes mosquitoes are caught and looked at, or they test them for dengue virus inside. So it's really important to keep an eye on that. Second of all is to try and improve our country's rapid recognition and response to arbovirus. And I think this is the most important take-home message, is that if you don't think about it, you never make the diagnosis. So even in a non-traveler, I always think, could this be dengue? Think about it, try and work out whether the patient warrants testing. And if it's not dengue, could it be another kind of arbovirus? And how do we respond to that? Thirdly, trying to test local populations. So what they do is they test for dengue serology, looking for IgM, IgG seropositivity in populations. And as soon as the numbers start increasing, then obviously you've got to increase your vector surveillance program and look for the dengue outbreak. So in local people, but obviously also in migrants and returning travelers, to try and look for increased transmission. And as I said, there is actually a research program up and running that assesses the prevalence and future risk in KZN. So areas to highlight, we don't want competent mosquito vectors at major air entry ports into South Africa, so being Cape Town and Joburg. So mosquitoes traveling in aeroplanes from endemic areas. What does make things hard is that it's a bit easier to control in an aeroplane where they spray and can use insecticide and things like that. It's not going to get into the person's suitcase if there's a mosquito in there, but certainly a mosquito that's flying around in the cabin. But we know that the vast majority of our people and most people in Africa are not able to afford airplane travel, and so our ground migration is really significant. People and goods are transported by road, and that's a lot more difficult to control. In KZN, we need to look and make sure what's the competency of the vectors. It is a tropical area. It could potentially be a hotspot. We've also got the port in Durban with ships coming in at this point, lots of people. And so we could potentially introduce viremic people and infected mosquitoes into these areas, which are arbovirus permissive areas, KZN more than Joburg, which is quite chilly. The next thing is to be able to try and even identify those who are asymptomatic or mildly viremic because they are infecting the mosquito. And this is where the introduction of the arbovirus and the dengue goes unnoticed for a couple of years. And by the time you realize it, you've established an endemic cycle and it's over. You'll never be able to control it after that. But how do you reach these people? If you're asymptomatic or got a mild flu-like illness, you're not going to go to the doctor. You're not going to seek care. So that's really difficult. And in these countries around the world where transmission has just gone crazy, it's exactly because of this, because these endemic cycles have been established. Testing is really difficult. There's very limited access even to serology. The testing is expensive. And so this is another sort of obstacle in the diagnosis of dengue. So you've thought about it, you're worried about it, and now you're in a place where you've got to send blood to a big city, Joburg, to the NICD potentially to do your testing. And by the time you get an answer and the funds to do it, it's maybe quite a few days have passed. So early recognition and diagnosis are really key, and we know what to do, but we struggle sometimes with the implementation. It's a huge challenge. So I hope with that I've told you and taught you something new about dengue, and you'll think about it, you understand a bit more about it. Watch the space for the 2024 vaccine recommendations, which we think are going to change. And thanks for listening, everyone.
Thanks, Kim. That was fantastic. Really nice. And I'm just looking through the chat over here. So I think Dave and Stephen Korsman are both saying about the risk, obviously, of climate change, because there were KZN outbreaks in the past, in the 1930s, which you highlighted, I think, presumably brought in at that point.
Exactly. It's in that article. One of them was the late 1920s.
That's right. Yeah. Sorry.
28, 29. Yeah.
And then a couple of questions. So what do you know what testing is done in private labs at the moment, if you suspect dengue in a returning traveler, say?
So AMPAT still sends the test to the NICD. Lancet can do serology and I think PCR. But it depends where you are. In the first week, you'll send a PCR. And if it's more than sort of 5-6 days, you'd send serology. But only Lancet will do the serology testing, not AMPATH.
Got it. And then a question from LB asking where in Africa have the recent imported cases been from? I don't know if you...
You mean from Africa to South Africa?
Yes, sorry, yes, yeah.
Yeah, I'm not sure on the latest data. There's no we don't have that data available sort of on the website, NICD website or anywhere. But you've probably seen a few, Albie, and might know. I haven't looked after dengue patients ever.
I've made you co-host, LB, if you want to add anything, because
Yeah.
as you said, I'm sure you've got some useful experience too. And then as LB saying, we do know of cases from Mozambique, and then in the report, I think, yeah, there was some from Angola, which is interesting.
Yeah.
And then looking through, how sensitive and specific are the rapid tests?
So the rapid tests are usually antigen related, and the sensitivity specificity is not bad because it's quite a, and they've used a very specific part of the virus antigen, and so but they're still around 85%.
Okay. I'm just looking through some of the comments. Sorry. Yeah, and shades of COVID, which I think you highlighted nicely. Very similar sort of pattern, right? The initial viremic phase and then the inflammatory phase and all that. And then, yeah, a couple of people asking about why it did fade away in South Africa. So I know you did mention it a bit, but it seems odd if we have the right vector. Is it just other climatic conditions? Or as you said, maybe we don't know the vector competence. Maybe the specific ones we have are not very good at it.
Yes, luckily, those three sort of transmission outbreaks which we've had, where there's been some local transmission, just died out. They don't say in the article what stopped the transmission. So that would be interesting to know. But and they're quite old, these cases. So I'm not sure that they were able to do that kind of testing then, or if they knew. But it seems to be vector competence. I think the weather patterns. So some of them were in really wet, rainy times, and then it dried out. The mosquitoes disappeared. Hot, dry summer, for instance, and that played a role. Super cold in Joburg, so hopefully it won't get here. But yeah, they don't really
We
say
don't have
why.
water anymore, so it's good. We find.
Yeah. No, that is a good point. There's always a silver lining, Jeremy.
I see, Lucille, you unmuted. I don't know if you wanted to say anything.
Yeah, just a couple of things. That was an excellent talk, Kim. You really covered it extremely well. So just a couple of comments. Those earlier outbreaks were related to imported tires, and for quite some time, they had some surveillance of imported tires. I don't think they actually do it anymore, and they came in with some infected vectors. So the issue about local transmission is you need to have a number of things. You need to have the competent vectors, and certainly we have IEDs. I think they're even in the garden here. But you need viremic people, and the viremias are really very short, and you need the vector and the viremic person to come into contact with each other in kind of a, an adequate size to perpetuate transmission. So I think we were quite lucky, but we're very vulnerable in northern KZN. And they are going to set up a cross-border surveillance with Mozambique and hopefully KZN to look at what's going on there. I think if you spoke about which countries, I think Mozambique, definitely Angola, as Albi's mentioned, we've had from Dar es Salaam, we've had from West Africa. I think it's very underdiagnosed, under-recognized. I can only remember most of them have been mild. They've had quite severe thrombocytopenic falls, and you get quite alarmed. But I only remember one or two that complicated, and they were not hectic, but they both got better.